Good afternoon, everyone. My name is Daniel Cho, and on behalf of the Ontario Public Health Association, I would like to welcome you to today's webinar. Before we get started, I would like to point out a few things. First, at the top left-hand corner, you see a materials pod, and you can download a copy of the slide deck from there and take notes during the webinar. Also, please feel free to share comments and questions into the Q&A pod at the bottom left-hand corner, and we will address as many as possible following the presentation. And if you require technical assistance, please chat with OPHA host 1, and a recording of the webinar will be made available on OPHA's website shortly. So today's webinar will be about a recent report published by the Ontario Chronic Disease Prevention Alliance, or OCDPA, released in November 2016, titled Determining Quality Chronic Disease Prevention Indicators in Ontario. This report presents a much-needed comprehensive framework of 52 indicators for key chronic disease risk factors under the categories of unhealthy diet, physical inactivity, tobacco use, high-risk alcohol use, and mental illness. In this webinar, you will learn how the quality indicator framework encourages the viewing of risk factors in parallel across chronic disease and supports collaboration, and also about opportunities of how you might use the quality indicator framework within your work setting and or practice. To present the webinar, I'm joined by Dr. Norman Giesbrecht, who is an Emeritus Scientist at the Center for Addiction and Mental Health, and an Adjunct Professor at the Dalla Lana School of Public Health at the University of Toronto. So Dr. Giesbrecht, thank you so much for being with us today, and I will now turn it over to you. Thank you.
Thank you. I'll skip that picture. Thank you. I'm very pleased to be working with OPHA to share the outcomes of a recent project by the Ontario Chronic Disease Prevention Alliance, also known as the OCDPA. Thanks for the opportunity to speak about this project. Elizabeth Manifo was a project consultant for the last 3 years. Her background is in public health, and my training was in sociology. We both have a strong interest in intersectoral collaboration to address chronic disease prevention and health promotion. The Quality Indicators Framework is a provincial project that aims to bring together various sectors across diet, physical activity, tobacco, alcohol, and mental health sectors by focusing on shared modifiable risk factors for chronic disease prevention. The focus of the project I'm sharing with you today has implications across many sectors and risk factors focus areas. We also would like to acknowledge the Public Health Agency of Canada for funding phases 1, 2, and 4 of the project. I would like to spend a few moments telling you about OCDPA. The OCDPA was formed in 2003 based on the need to address integrated action and collaboration on the issue of chronic disease prevention. The group is made up of 22 partner and member organizations that provide overviews on the determinants and risk factors of chronic disease, address the economic cost of chronic disease in Ontario, and also identify priorities for action. Ultimately, the OCDPA is committed to improving the health of the Ontario population. For more information about the OCDPA and various projects that they are doing, I would encourage you to visit the website as indicated in the lower right corner of this slide. The information I'm sharing with you today about the indicators framework is also available on a section of the OCDP website. I would like the project I'm talking to you about today, the Quality Indicators Framework, is a knowledge mobilization product that aims to make explicit information like data and work to make it into tacit knowledge for end users. That is information that is in our heads that we can rely on for practical and useful purposes. In order to get a sense of how you perceive the use of data, that is facts, figures, numbers, and practice, please take a few minutes to log on in your response. All the time, sometimes, not enough, and never. Okay, thank you. It looks like there's a range of responses with most people, the majority indicating sometimes. To help frame our discussion, we have 3 learning objectives for today's webinar. The first is to describe how the indicator framework encourages a view of risk factors in parallel across chronic diseases. The next learning objective will then build on the awareness of the indicator framework by being able to identify opportunities where and how the framework can be used, looking at the dimensions of research, practice, and policy. And the third learning objective includes an interactive component of today's webinar where I would like to hear from you about how to use this working for you in practice. This will also be an opportunity to learn from you about initial thoughts about the framework or what suggestions you might have for improvement or increased meaningful use in your practice. This is one of the most valuable aspects of today's webinar, as the OCDPA is invested in working with researchers, practitioners, and policymakers to provide relevant, useful tools and knowledge products. Elizabeth Manifo was a project consultant who organized all aspects of the project as will be described today. I chair the advisory group. Of specific relevance, given the indicator framework itself spanned across 5 risk areas, including diet, physical activity, tobacco use, and alcohol consumption, and mental health, you will see their representation across all these areas in the project's advisory group members. I would like to acknowledge the valuable support and insight provided by this project team over the last few years who made this work possible. It was essential that all areas are represented to ensure the validity of the project. The indicators or report card approach has been used in many areas of Canada. For example, to assess drunk driving policies across the provinces and territories, to rank universities in Canada with regard to the quality of the education available, to assess provincial health care, to compare the provinces on the strength of alcohol policies, to provide an estimate of the quality of health in major Canadian cities. One of the advantages of this approach of doing comparison is it leads to stimulating action to make things better. This indicator framework project is really seeking to address the following question. How is Ontario doing when it comes to preventing chronic disease related to the major risk factors, proximal risk factors? The major risk factors for our project are physical inactivity, unhealthy eating, tobacco use, high-risk alcohol consumption, and mental illness. We have seen a notable shift over the years in how alcohol is measured as we move away from relying solely on economic measures to broaden understanding to the factors that impact well-being and quality of life. This helps us give a sense of what's working and where we need more attention. The initial purpose of the project was to collect and provide baseline information that will help us to understand trends and major risk factors for chronic disease in a clear and comparable way. Utilizing a single framework would then allow us to track and compare risk factors and eventually document trends on a periodic basis. For today, I will focus on showing you our process and outcomes in identifying a short list of indicators and associated measures to the 5 proximal risk factors that I just mentioned. Excuse me. Now, while I provide you with a rather simple question that needs an answer, the reality is the situation around chronic disease prevention is much more complex. This graph attempts to illustrate the direct and indirect pathways linking key risk factors to chronic diseases. Furthermore, while it may be easier to identify risk factors and acknowledge them as modifiable, it is critical to then ask the question of the vectors that underlie the risk factors. What I mean by that is we know that tobacco use is a risk factor for cancer and chronic disease, for example. But what influences smoking behavior? The point I'm trying to make is that no discussion on this topic is complete without addressing the social determinants of health as an underlying causes of disease. We are fortunate in Canada that the social determinants are embedded in our discourse of public health. Having said that, one positive that I would like you to take away from this image is that risk factor that you see highlighted at the top of the graph influences one or more of chronic diseases, which means there is an opportunity for cooperation and collaboration to build capacity and leverage the work being done by specific groups and disease foci, not only to not only broaden the reach, but deepen the collective impact. At first, we focused on bringing these messages across in a clear and meaningful way. Looking at Ontario, we see the prevalence of chronic disease affecting a very large sector of our population, 90% in fact living with at least one chronic disease, and 79% of deaths being affected by the major chronic diseases. This results in indirect and direct costs to us as individuals and as a society. You see here upwards to 40% of healthcare costs in Ontario are estimated to be related to unhealthy behaviors and socioeconomic barriers. Given these starting numbers, we know that a major public health need is to measure our impact in preventing chronic disease to ultimately influence the health and well-being of the population. As mentioned earlier, the project focuses on 5 risk factors, realizing there are also important distal risk factors that impact chronic disease in Ontario, such as social determinants of health, the built environment, and others. In order to address increased risk of chronic disease and focus our efforts on prevention, the project's purpose was to meet the need of, 1, collecting baseline information to help us eventually understand trends. Baseline information means we have a starting point of data, that is collecting the beginning, if you will, in order to have a marker to refer to in the future. 2, to guide what baseline data we need to collect, the purpose of the project was to identify a short list of indicators. In this context, indicators are the language you use to say what data we need to help paint the picture in understanding how Ontario is doing across the 5 risk factor areas. By collecting the baseline information of selected indicators, we will be able to in the future to refer to the baseline and track trends by asking ourselves, how are we doing? Are we doing better in addressing this risk factor that influences chronic disease? Are we losing momentum and going backwards, or are we remaining at the status quo? A brief mention of our message is provided. Since it is important to have an understanding of how we approach this work in order to be established buy-in and its use. The project has 4 phases over 3 years. I will go into a brief description of each of phases 1 to 3, and then we'll discuss our current progress on grade 4, which you can see by the slide is currently underway. The first phase was to identify a list of indicators which was compiled by the members of the advisory group. The second phase focused on validating the selection of indicators by involving a group of experts within each respective risk factor field. Using a snowball sampling technique, key experts were asked to comment on the identified indicators, suggest what was missing, and potentially should be removed. Experts also had the opportunity to comment on other risk factors areas outside of their dominant area of practice to encourage a systems thinking even in the indicator identification stage. Once the indicators were validated, a third phase was to collect the data on each of the indicators. That is, if you wanted to collect the data on the percentage of the population who reported biking or rollerblading to work, looking at physical inactivity, we confirmed the existence of the data set and obtained the data specific to the Ontario population. The first question we had is, what type of indicators were we looking for that fit within the scope and purpose of the project? That is, what are we looking for exactly? The advisory group established selection criteria for the indicators, which basically means the characteristics for the indicators to be included and the characteristics of what would be excluded. We looked for indicators that are first and foremost directly related to one of the 5 proximal risk factor areas previously outlined: diet, physical activity, tobacco, alcohol, and mental health. The second characteristic is that data had to be currently available for collection. That is an interesting criteria that came up frequently throughout the 4 project stages. We also wanted to focus on indicators that emphasize the adult population within the context of chronic diseases. However, exceptions were made for indicators where it made sense to look at younger age groups given the desire to promote healthier habits later in life. The indicators also were asked to move forward for inclusion and eventual validation, phase 2. Just before going into the number and type of indicators that were identified, I would like to acknowledge that by using a population-level framework to guide the discussion, both what we call behavior-level indicators and system-level indicators were identified. This recognizes that what the literature tells us about the interdependence of programs and policy that address an individual's behavior or lifestyle choice within the general context of system or socioeconomic level indicators. Similarly, as the arrows show on the image on the slide, the interdependence really moves both ways. That is, our behaviors as individuals impact the outcome to society, and societal indicators may influence the individual choices. To clarify this distinction, you will see 2 indicator measures that were selected for the physical inactivity focus area. On the behavior level, the data provides the percentage of the population who report their individual level of activity. At the system level, the indicator speaks to the accessibility of location to enable or promote physical activity. Available data were more readily available for behavior level versus system level indicators, suggesting the need for further investigation in order to invest further investment into broaden or system level indicators, given their impact on the population's health and well-being. This slide illustrates the main steps involved in identifying indicators. You can see that for each risk area, both system and behavior indicators were selected. Once the initial list of indicators was created by the consultant, Elizabeth Manifold, and members of the advisory group, these were sent to Ontario-based experts on each of the 5 risk factor topics. This led to some being dropped and others being added. The net result was that our list grew from 68 to 72 as indicated in this slide. The framework was populated with the most relevant and recent Ontario data, drawing from recent surveys and other tabulations. This slide summarizes the progress of indicators identified, validated, and populated over the 3 project phases. To summarize, overall, 319 indicators were reviewed for inclusion. Each advisory group subgroup focused on their particular risk factor foci and collaborated as needed to refine the long list to a short list of indicators. Eligibility criteria such as indicators' validity, relevance, and feasibility and other criteria adapted from the Canadian reports focused on developing quality indicators. As the graphic shows, the result was 68 indicators across 5 risk factor areas. So while at the outset we expect to track down data for 68 indicators, following validation by experts, the list was 72 measures. In the end, data were available for 52 indicators. The advisory group considered several options to convey the data in a meaningful and practical way. The team worked with a graphic designer to illustrate the main findings, and the infographics were designed to provide a coherent clear, and useful product across all 5 risk factor focus areas. The graphics went through several iterations and were informally reviewed through the OCDPA member and partner organizations and networks for input on accessibility, palatability, and so on. Furthermore, it was designed to better equip knowledge users with an action item to bring into practice. So the next 5 slides provide a quick illustration of our main results. They're not comprehensive, but we've focused in on a number of indicators from each of the 5 areas. Here you can see several indicators related to unhealthy eating. This infographic also points to the direction of desired change in order to reduce risk of chronic disease by encouraging healthy eating through policy programs and lifestyle changes. So you can see we want to see some decrease in some of the numbers, and we also want to see an increase in access to fruit and vegetable, and overall dietary increase in some numbers. Here is a slide for physical inactivity, and again you can see the current percentages, and then what we'd like to see some increase in workplace and school wellness, also some increase in physical activity, and a decrease in sedentary behavior as indicated by those indicators in the percentage there. Tobacco use. Similarly, we want to see an increase in the price, increase in taxation. We want to see an increase in smoke attempts and an increase in access to smoking cessation aids in the province of Ontario. High-risk alcohol consumption, a decrease in overall consumption, a decrease in people drinking at risky levels, and an increase of an awareness of risk as indicated in the lower left corner of this slide. Some increases in prices are desired, and also a decrease in the density of on and off-premise outlets. On refers to bars and restaurants, and off to liquors and beer and wine stores. We'd also like to see an increase in some of the mental health indicators, and also a decrease in some others. And decrease in discrimination, for example, and also a decrease in stress as indicated in this slide. So that's a quick synopsis of the results, but all the results are available in the report and it's on the OCDPA website. And so how can you use the framework? After 3 years of work invested in the project, the most important question comes, so what? I can start by telling you how do we envisage the stakeholders across the risk factors using this knowledge. On the far left, you'll see suggestions about using the indicator framers in research. Perhaps it can help explore the relationship between shared modifiable risk factors. It may help guide questions on the gap of literature that exists that would help be useful to continue to prevent chronic diseases in Ontario. In practice, we might also think about how we can use the indicator framework to make evidence-based decision making and better enhance the relationship between practice and research to inform research on what additional data is needed. You can also see some policy implications, greater access to services and resources that foster healthy choices, and also reducing harm risk or harm by controlling access where links to chronic disease are evident. The 5 infographics that I showed a few minutes ago provide illustrations of what needs to be changed in order to promote health and reduce the risk of chronic disease in Ontario. How can this change be achieved? Here are a few policy recommendations that the advisory group members have put together forward. The full list is in the report and also summarized at the end of this slide deck. And I've chosen one from each of the risk factor areas. Unhealthy eating. Support community planning and partnerships that encourage mixed land use and healthy urban planning that enhances safe and sustainable access to healthy food. Physical inactivity. Establish policies that provide fee assistance or subsidized programs for low-income participants, as well as free universal programs, drop-in swimming, supervised playground and programs, for example, for all residents. Tobacco. Create a comprehensive smoking cessation system that would link and integrate existing cessation programs and activities for smokers. High-risk alcohol consumption. Ensure effective controls on alcohol availability by ensuring that there is no increase in hours of sale, that the overall population density of on- and off-premise outlets per capita does not increase, and not undertaking further privatization of off-premise alcohol retail sales in Ontario. Building capacity among mental health service providers to deal with chronic physical conditions experienced by people with serious mental illnesses. So let's start the dialogue now. Take the time to consider the multiple choice options and to answer the following question: when will I use this indicator framework? The next day, the next week, over the course of a year, or maybe not sure? Okay, thank you. So we can see that quite a few people indicate not sure. I think about 44%, and about 50% over 51% over the course of the year, and a few the next week. Thank you for your contributions. To complete today's webinar, I will lastly share with you some of the activities related to knowledge mobilization. This example has resonated for most with me when it comes to discussing the mechanics of knowledge mobilization. Research tells us it is not enough to simply feel you will disseminate your findings without a target or planned approach. What this graphic is suggesting is, in the colored bubbles, are some informal steps in the knowledge mobilization process. First, becoming aware of receiving the information, followed by reading and understanding it. This hopefully follows with someone appreciated and resonating with their work they do, leading into informed decisions and then taking action on these decisions. What's highlighted in the blue outside the bubbles is the opportunities in which this process can fail. This can be as simple as, I didn't know this existed, which may be common in our area of information overload, or not have capacity to spend our time to view it, or follow up to ensure what to understand. This process may also fail if we don't see the value of how it will add and enhance our work, which eventually may lead to the knowledge product not being involved in our decision-making or action taken. It's a bit overwhelming to think of all the possible areas where work that has been committed to with good intentions falls short of the target goal. The OCDPA is currently working on formalizing a knowledge and mobilization plan we have found using the example provided by the Ontario Centre of Excellence in Child or Youth Mental Health relevant to our work. This process requires you to think through your knowledge mobilization efforts by answering the what, why, who, how, and when. This is helping us organize our efforts and think about the resources required to sustain the efforts of this project, especially on the next steps that will build off the baseline data and collection for future tracking and comparison. For further information, examples of this knowledge mobilization process, you can visit the URL provided. It's the bottom of the slide. In tandem with developing a knowledgeable mobilization plan, the OCDPA has been working on broad dissemination through provincial and national conferences and other stakeholder opportunities. There's also additional work being done to raise awareness of the missing data, as well as the indicators on the wish list, where data is currently not being collected, to further enhance data monitoring and surveillance in Ontario. Given that the report has clear policy recommendations across the 5 risk factor focus areas, the OCDP and its members are working towards an action plan to foster this process, as well as opportunities for future. And also to plan for future data collection, it has been identified by interest groups throughout the dissemination process, that the framework will have its true value in being able to track and compare the impact on chronic disease. So I would like to thank you for your attention today. As previously mentioned, the full report and infographics are available for download on the OCDB website. For future information about the OCDB and this project, you can contact the OCDPA Secretariat in the email provided as on this slide. If there's time, I'd like to try to address any questions or comments. Thank you for the opportunity to participate today.
All right, thank you, Dr. Giesbrecht, for the presentation. We do have some time for questions and your comments. So please feel free at this time to share your comments or questions in the chat box at the bottom left-hand corner, and we'll try to get through as many as possible. Dr. Giesbrecht, I know in the slides there were 3 questions that we thought maybe could stimulate discussion. Do these indicators make sense to your area of practice? How does this work complement existing work or reports? And what would help you use this framework? What might limit it? Would you like to maybe solicit their comments on these questions?
Yes, please. People could maybe bring their comments on those 3 areas and others. Thank you.
Sure. So I'll type those into the chat box. So a few questions have come in. First, regarding the infographics, is there a way to access these infographics? Are they online for download or anything like that?
The infographics are available on the website along with the full report. So if you go to I think we may have to go back to. Oh. Oops. Trying to get to the website.
Is that the OCDPA website?
Yeah.
Do you know which slide it was on?
So near the back, near the last slide. I don't know, it's something. Okay, let's continue with the other questions. We'll find it.
Sure. And we'll try to find the link and post it up. So we had we have a dialogue going on in the chat box about it's regarding the healthy eating infographic. And here, let me just look at it here. And I think it's around, here it is. So if you go to the infographic on unhealthy eating in Ontario, the title says food security. However, the indicators are about food insecurity. So the suggestion was raised that maybe it should be called food insecurity instead of food security. Any comments on that?
Thank you for that. I think there's been some dialogue there, as people see in the chat room. food security or food insecurity issue is an important one. I think we did measure food insecurity in the report, and were used in the indicator as indicated by one of the respondents in the chat here. But I think the fact that if you look at that infographic about unhealthy eating in Ontario, I think that we are trying to encourage decreased insecurity.
All right, thank you for that. And I am posting in some questions that we would like to hear your feedback on. So again, they are, do these indicators make sense to your area of work or practice, and if what's missing, if there is any? Number 2, how does this work complement existing work or reports? And number 3, what would help you use this framework, and what might limit it? So we'd love to hear your feedback on that, and you could feel free to share those in the chat box.
Can you put the infographics back up? I don't know why mine's blocking. Sorry.
Sure. Yes, we'll put up the infographic. Dr. Giesbrecht, we have a comment. Some of these indicators make sense for our organization. However, as a First Nation organization and completing health surveillance for on-reserve populations, some of these indicators are greatly influenced by other factors, and there is little to no data available on these topics to even establish a baseline. So any thoughts on that?
Yeah, thank you. I think that's an excellent point. The scope of this project was at the provincial level. It would have been ideal had there been the resources and the time to be able to provide detailed information for specific sectors, for specific groups, and so on and so forth. But this was a project that was focusing on Ontario per se, and of course there are limitations with that, and also some strengths. I think that that's an excellent point. That maybe down the road when we try to do this again, that we would try to do both. We try to keep track of the situation for Ontario, and also possibly get some more focused information for some of the other sectors and population as indicated by the comments. We're trying to get the infographics up, by the way. I'm not sure mine is not going up. I don't know. It's not showing. Okay, you want to...
Thank you, Dr. Giesbrecht. So we have a question here. There are a lot of great recommendations represented in the infographics going forward. Are there recommendations that the OCDPA sees should be prioritized? If so, perhaps priorities should be indicated on the infographics.
That's an excellent point. We wanted to present a very strong snapshot of each of the indicator groups for each of the 5 areas. And the way to prioritize, I think, is to look at what's feasible, what's currently going on, and look at our policy recommendations, which I highlighted with 1 or 2 examples, and I provided in the full report. So I think that the issue of prioritizing is a very important one, and I think the general considerations with regard to prioritizing include what's currently going on in Ontario, what is the potential impact of the policy recommendation, What is the scope of the policy recommendation? How many people will likely be affected? And what is the chance of it being successfully implemented? As a first pass, I think it's very important to provide a fairly strong and fairly broad overview of the level of indicators across these risk factors.
Thank you. We have another comment about the unhealthy eating in Ontario infographic. So with regard to unhealthy eating, would there be value in trying to figure out some system-level indicators similar to those in alcohol and tobacco? Access to unhealthy and healthy food options in a community, for example.
Thank you. That's also a very important point. We discussed, I think the group, as I recall, this is going back, so we discussed that topic at several points. And one of the things that may be a system level thing to consider, but whether these data are available, and there's also a problem with regard to classification, is that, how many, quotes, fast food outlets there are in a community compared to, for example, a density of grocery stores where you can get access to healthy food. And so I think that those would be sort of system level things to consider for example, with regard to that particular topic. But some of these numbers may be difficult to get, and there is also the difficulty of classification, because some places may have both a combination of healthy and less healthy food. So I think that's an issue to have further consideration.
Thank you.
Could I ask guest 2 to indicate what he or she means by perception of eating habits is not helpful? Please.
While we wait for that, we have a comment from about, I think it's in response to our second question, how does this work complement existing working reports? And they just commented saying that this work complements the CCO, Prevention System Quality Index indicators. So just want to mention that.
Yeah, thank you. They are very complementary. The CCO report includes other dimensions and doesn't include all dimensions that we have here. It also is focused on the local level, which we did not do, and it also has some other aspects that are dissimilar from ours. So I think the two approaches are quite complementary.
And Dr. Giesbrecht, while we wait for some more comments from guest 2, we have a question here. Were the indicators considered for the OPHS standards, so the new Ontario Public Health Standards? Any comments on that?
Yes, we looked at those standards, and they were part of the discussion when we were developing our indicators. Thank you. We have the infographics are up on the screen now. You should be able to see them.
We have a question about sugar-sweetened beverages. Would it be feasible to look at consumption of sugar-sweetened beverages in the future for unhealthy eating?
I think that would be feasible. I think that's an area that's very, very commonly in other jurisdictions, and I think that's an excellent point for looking at that in the future. Do people want to discuss any of the other? Oh, sorry, this thing is jumping around. can we go back to the infographics, please?
Sure.
Shall I do it, or you're going to do it? Okay. Yeah, let's go back to in order. Okay, we've talked about diet. Can we go back to the next one, which is, I think, physical activity? Does anyone have any comments about that? Questions or comments?
Dr. Giesbrecht, we have a clarification from guest 2 regarding the perceptions. And so they're saying that perception varies. What is the perception based upon? Is it the Canada Food Guide, sugar, fat, or salt? Similar to perception of healthy weights, actual measures would be better. Any thoughts on that? I think it's a reference to the bottom left-hand corner, where it's the overall dietary intake.
I think this is an excellent point. This is, I think, from a survey, and so I think that I do not have the details of how that question was phrased in the survey or any of the preamble at my fingertips, but I think that's an important point. And so I think that needs to be considered in going down the road. Thank you. So no comments. Look, maybe somebody's typing. Okay, somebody's typing. Where?
There is a comment about this physical activity one. Self-reported data is particularly difficult with this topic of physical activity. That's from Hamilton Public Health, I believe.
I think that's an excellent point. But that is the case for many social areas. If you want to find out what's happening at the individual level, you either have to have a very rigorous and very expensive monitoring system, testing through doctors or nurses, or you need to ask people what their behavior is and what their activities are and so on and so forth. At the population level, to get data on these things is very good, but it doesn't really doesn't provide you with individual breakdown. So if I could use the alcohol example, which I know something about, if you get information from the liquor authorities as to how much alcohol is sold, you can estimate with pretty good accuracy how much alcohol, how many bottles of beer and wine and so on and so forth are sold in the province of Ontario in a given year. But you don't know, is it how it's distributed? Does it involve more drinking among young women or more drinking among young men, or does it involve different ethnic groups drinking more or less? And the only way to get that information is to do a survey. And a survey is one of the realities with all its limitations.
We have a quick question. When the information was gathered for this physical activity, were people given a definition of moderate or active activity? Moderate versus high.
I should mention, and maybe I missed it in the introduction. Thank you, of the opening part of the presentation. We did not collect new data for the indicators thing. We used existing data. We used existing information on tobacco sales, on the price on the taxes on tobacco, on smoking cessation numbers from other surveys. So our indicator report was based on existing information we did not collect new information. So that had strengths, and because we were able to make use of data that were already available and did not have to go into a huge expense to collect new information, but it also had limitations that we were limited to how these questions were phrased, asked, and how the survey and other information collection was undertaken.
Great. We have a question. Is there an opportunity to influence, so this might harken to what you just mentioned about the data collection. Is there an opportunity to influence change regarding the survey questions for the various sources you are using? And would OCDPA have the ability to advocate for changes that would better address the systemic questions?
Thank you for asking that question. That's really an excellent point. We are looking now to try to figure out how we could fill some of the gaps, and this is related to your point, fill some of the gaps that we couldn't, where we couldn't find data. As you remember, we had 72, that was our wish list of finally, it was, I think, of 72 indicators, and we ended up getting data on 52. But also, I think that we felt that, as somebody else indicated a few minutes ago in the chat room, that we felt that there was some greater need for more systemic level indicators, but also focusing on the individual levels, which is the implication of this question, I think, from Hamilton. I think there is a need to look at these questions and all of them very critically. What purpose do they serve? Are they the best way of phrasing the question? And are they going to give us as accurate information as possible within the limitations of survey research? So yes, we would hopefully have be able to provide some feedback as a result of this undertaking to the various people, groups, and organizations that conduct these surveys, and possibly suggest some ways in fine-tuning some of the questions, or maybe even having some sort of a system whereby they ask the questions two different ways, and so that we can see if you get a stronger answer and a more representative answer by doing it that way. I don't understand. Agree with Algoma that would be a good collaboration. What does that refer to?
Yes, just above that, there was a comment from Algoma Public Health.
Oh, yeah, thank you. Yes, okay.
So I think they're referring to the locally driven collaborative project working on food literacy, and would it be possible to connect and look at food literacy as an indicator, as this can play an important role for healthy eating?
Right. Yeah, I agree. Now, is there any comment on the tobacco use infographic? It's quite surprising the access to AIDS is actually relatively low, I think. And I think that Ontario has one of the lowest tax rates with regard to tobacco across the country. Maybe not the very lowest, but it's definitely not the highest. Okay, we're going to move to the alcohol one and see if there's any questions about that. Yeah, thanks. So here you can see again, to illustrate my point of a few minutes ago, you can see a combination of what may be considered official statistics on the far right. So you can have some minimum price, outlet density, and so on. These are official statistics based on official statistics. And then in the top left corner, that's again official sales information. And in the middle left, this is based on self-reported information. How many people said they exceeded the lowest drinking guidelines, and so on and so forth. And the relatively low percentage of the Ontario population were aware of the lowest drinking guidelines, 21%. So I think there's room for improvement, and there's also some good things going on. Oops. Can you go to mental health, please? Okay. So in some cases, we did, for mental health, it's in the report, full report, we did not have Ontario-specific data, and we used Canadian data for some of these indicators. So we want to increase people who perceive their mental health as good, and you also wanted to decrease people who felt they were in poor mental health, and also try to decrease discrimination related to mental health issues. Are there any final comments that people would like to pose, please?
And Dr. Giesbrecht is following the webinar. If they people would like to connect and learn and share more thoughts, can they email the address that was posted before, the OCDPA at on.long.ca?
Right, and the website for OCDPA is www.ocdpa.ca. So as you can see in the bottom of this mental illness infographic that's just up on your screen now, is that up on our screen too? Right. You can see in the bottom right, that is how you can go to the website, please, and find the full report and the infographics.
All right, so we are close to 1 o'clock, so I think we'll bring the webinar to a close. So first, a big thank you to our presenter, Dr. Norman Giesbrecht, and also to everyone on the line for joining us today. You'll be receiving a feedback survey in email. Please take a few moments to share your thoughts with us and ideas. All responses are anonymous, and your suggestions will help us to improve our webinar programming. So again, thank you so much, everyone, for joining us, and hope you have a wonderful rest of the week. Thank you.
Thank you very much.